This episode of the Jerry Paul Podcast is CME eligible.
To claim credit, please go to the CME tab on jerrypal.org.
Welcome to the Jerry Paul Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, who do we have with us today?
Today we are delighted to welcome from the great state of Canada... From the great country of Canada.
Oh, we're going to get a lot of comments on
terrible.
That one, Alex.
That's terrible. We're delighted to welcome Eric Wong, who is a geriatrician and researcher, PhD candidate at the University of Toronto, who practices geriatrics at St. Michael's Hospital. Eric, welcome to the Jerry Pal Podcast.
Thank you. Thank you for inviting me.
And we're delighted to welcome Thiago Silva, who's a geriatrician from Brazil and is currently a T32 postdoctoral research fellow at UCSF in the Division of Geriatrics. Thiago, welcome to Jerry Pal.
Thanks. Great to be here.
So we're going to be talking about comprehensive geriatric assessments, a topic that I have a vague, foggy idea exactly what it is, but we're going to be talking about what it is, who should get it, and what's the evidence base. But before we go into all of that, Thiago, I think you have a song request for Alex.
Yeah, our song request today is Getting Older by Billie Eilish. And I like that song because it kind of, shares a reflection on getting older, cumulative life experience. And that's why I requested that song.
Isn't Billie Eilish like 18?
Well, maybe in her soul, she's a little bit older.
For this comprehensive geriatric
or the 18-year-old
podcast.
Yeah.
It's a great song. She's such a good singer. Here's a little bit in my older voice. I'm getting older, I think I'm aging well. I wish someone had told me I'd be doing this myself. There's reasons that I'm thankful, there's a lot I'm grateful for. But it's different when a stranger's always waiting at your door. Which is ironic, 'cause the strangers seem to want me more than anyone before. Too bad they're usually deranged. Things I once enjoyed just keep me employed now. Things I'm longing for, someday I'll be bored of. It's so weird that we care so much until we don't.
Wonderful. Thank you, Alex.
Pretty good.
Good song, Thiago. All right, Eric, I got to ask, what the heck is a comprehensive geriatric assessment?
So the comprehensive geriatric assessment, in my view, is just sort of like the most common tool that a geriatrician uses to assess an older adult with complexity or with frailty. And there are a lot of definitions. And I think there was an umbrella review a few years ago discussing what the definition is, because there's so many out there. But I think the commonalities include it being multidimensional. So it has to assess multiple domains, it has to identify geriatric issues, and it has to come up with a plan to manage those issues. That's my impression.
And Eric, you do CGAs in your practice, right? Comprehensive geriatric assessments.
Yeah.
What does that look like for you?
So basically, in our practice, in Toronto, generally, we mainly do CGA. So we mainly do consultations on new patients, whether they're in the acute care setting, in the rehab setting, or in the clinic. And some of us, for the outpatient clinics, we will follow people longitudinally. So the sort of the comprehensive geriatric assessment would be the first visit where we do a longer assessment, and then the follow-ups would be sort of more focused on the individual domains or issues that the patient has. But in general, we do the CGA. Like that's basically our main practice is doing CGAs.
Yeah.
And what domains do you cover?
We do a lot of different domains, but I think the most common ones are cognition, falls, mood, multimorbidity, polypharmacy, those kind of geriatric syndromes.
And Thiago, did you do them in Brazil?
Yeah, we do them in Brazil as well. And I guess one thing that I like about CGA is that I think it addresses one of the core principles of geriatrics, which is like establishing priorities. You have these older adults, frail older adults, very complex, a lot of things going on at the same time. And through a CGA, you kind of have an objective measure of, the problems that are going on. And then you can plan with your patient and their families, which should be addressed first and how to do that.
So I got a question. So I remember going back to geriatrics fellowship. Like I had my geriatrics clinic. I saw the patient individually. I talked with the attending. It came back. If I needed a social worker, I would get a social worker involved. Or if I needed the pharmacist, I'd get the pharmacist involved. And I hear about these other, what I always thought was comprehensive geriatric assessments, where like it was a big team. Each individual, like they were seen by the RN, a geriatric specialist, a geriatric pharmacist, a social worker. They were all coming up with their assessments. Then they met together and then they came up with a plan. Like it was this like half day, sometimes full day. Maybe it was more of the geriatric evaluation and management type clinic. Is that a comprehensive geriatric assessment, or was Eric Widera just coming in there as the lone geriatrician doing his best to do an assessment?
Yeah, the half day, full day sounds like big C, putting the C in comprehensive.
Comprehensive versus the Eric, maybe it was just the geriatric assessment without the C. No comprehensiveness in there.
Yeah, no, I think the definition that these authors came up with in 2018 included multidisciplinary as one of the requirements. I have to say that in Canada, and I can't speak on behalf of all of the different practices because they're quite diverse. There are some places where they do in fact have that, like an outpatient geriatric assessment would have different visits, whereas, at one visit, they do a pharmacist do a med rec, and then they may get, a nurse to do one of the history sessions. And then like PT and OT may see them separately. And then the geriatrician brings it all together and then does the assessment and plan. So there is that model. But I think the majority of geriatricians just kind of do most of the CGA themselves, or maybe with one or two allied health, but not with like a big team.
Yeah. And in your experience, Thiago?
Yeah, I think the multidimensional aspect of it is like probably the central piece. And then there are different ways that you could do that, by yourself or with a team. There are settings where there are geriatricians, as we're going to discuss, and then you might have other professionals doing these assessments. And you can even have like short, targeted kind of CGAs, which is another approach as well.
So it sounds like
the comprehensive geriatrician assessment. It's the comprehensive geriatrics assessment, which can be done by non-geriatricians.
Yeah, that's right.
Yeah. But it also sounds like there is a spectrum, right?
Yeah.
You can have a highly trained, multidisciplinary people with expertise in geriatrics, from geriatric pharmacists, geriatricians, like the whole works, seeing patients in different types of settings, to the other end of the spectrum where it's maybe less resource intensive than that, but potentially still doing the components of a comprehensive geriatric assessment, maybe not as intensive as that other end of the spectrum.
It might not be intensive, but like you're intentional, right? You're having this look into things that many times people don't really value in clinical care. And that's where I think, the CGA can help. That you're intentionally evaluating these issues, and then you can plan for interventions and care.
Yeah, and the intentional part, like, are those they may do screening tests beforehand, report outs, cognitive screeners, you're intentionally evaluating for geriatric
social
syndromes.
support. Yeah.
Okay.
And I'm still trying to figure out what's in there. So are geriatric syndromes always assessed? Like, is that an essential component of a comprehensive geriatric assessment? Like incontinence, for example. You mentioned falls, but are all...
I think it varies a little bit, right? But I think, like Eric said, you always have cognition. You always have like function. You're going to have usually some measure of social support, nutrition, polypharmacy. There might be sometimes some, falls, history of falls, sometimes a measure, some kind of resource utilization, kind of, whether they were admitted to the hospital or visited the ED, recently, sometimes it's a part of it as well. And mobility, mood.
Eric, anything you'd add?
Yeah, no, I agree. So there, the 5 M's, like I think, as mentioned, like those are great domains. And yeah, I agree. Like in our CGAs, we also do a review of systems where we kind of go through those things that might not come out unless you directly elicit them, like, urinary incontinence or, constipation, appetite, sleep, weight loss, that kind of stuff. So yeah, we include all those things. And then, sometimes in the right context, we would do, objective testing. So, cognitive testing or objective mood testing and in a scale. And also the physical, of course.
Mm-hmm. And I'm glad you mentioned the 5 M's, because that was going to be my next question. Like, how does this relate to the 5 M's conceptually? Because we're seeing this great uptake of the, what is it called? The age-friendly health system framework, right? Which includes I think they have 4 M's, but, you're probably adding the 5 M's. With 5th M is what? Multi-complexity?
Mind, mobility, medications, what matters, and multi-complexity. I looked that up because I want to make sure I got that right. I also never know. Am I supposed to use 4 M's or 5 M's? So
is that framework kind of replacing the comprehensive geriatric assessment? I'm just trying to figure out how they're related. What's the relationship between these two concepts?
Yeah, I don't think they're replacing, right? I think it's like CGA is probably a tool, a resource to implement the 5 M's.
Yeah, or is it specific population? Like I can imagine, like a comprehensive geriatric assessment. The word comprehensive means that you're doing a lot. Like, does everybody need a comprehensive assessment? Versus, does every older adult need? We should focus on the 5 M's. For me, that almost feels a little bit different. What do you think, Eric?
Yeah, like I think it depends on the purpose, right? In the context of where the practice is and the goals, right, of the practice. But I think like 5 M's is sort of an easy way to disseminate geriatrics knowledge to, say, non-specialists, right? To, general practitioners. And they can understand that, these are actually core geriatric concepts that if you were to do, say, internal medicine and you don't think about this, and you would completely miss very important geriatric syndromes. And it's easy to remember. It's a good mnemonic. And I like that it also says matters most, which is we always factor in patient preferences, right, into our consults. So I think it's more of geriatricizing, like big G, little g, kind of, if of the entire healthcare system. But I think for a CGA, we do a little bit more than that. And I think part of the problem is, if you're not systematic, right, sometimes you would miss issues. And so the CGA takes a long time because it's a systematic approach, so that we pick up on the issues that maybe others have missed, and I think a lot of the value does come from that.
And I'm guessing, Eric, you've been doing this for some time. Do you just kind of remember everything? Do you have like a structured CGA assessment that you go through every single time?
Oh yeah, like it definitely, and I'm admitting this online to all of my preceptors who may watch this, but it did take me a long time to actually memorize all the elements. Like even though, in training, like in our geriatric residency, we do it all the time, but, we use a template generally because it's such a long consult. But I have to say, even after independent practice, it took me, a bit of time to actually get it down. But now, of course, like after doing it for a number of years, it's more or less memorized. I could do it, I could do it at best with a blank piece of paper. And
how long does your comprehensive geriatric assessment take?
So, as a standard in where I practice in Ontario, I think the standard is 90 minutes for a comprehensive geriatric assessment, but it does vary. So, in some contexts, some geriatricians may be a little bit more focused, depending on the reason for the referral. And in a lot of cases, we end up taking a lot longer because there's a lot of complexity. There's a social aspect. There's multiple family members, informants who we need to get different perspectives of. So it would not be surprising for us to take up to 3 hours. But in terms of the standard as what because in Canada it's a single payer health system, so all the billings go through the government. So the government's requirement is 90 minutes for that CGA.
Yeah, I agree that it would usually, like for us in Brazil, we usually take about an hour, but it will vary anywhere between like 45 minutes and 2 hours, depending on the patient.
So does it work? Like, what evidence do we have? And I think there's probably some connection to kind of the body of evidence we have for palliative care, because, in that evidence is like, oh, does palliative care work? My response is, what do you mean by palliative care? Like, what components do you have to include to be called a palliative care intervention? Is it primary palliative care, specialty palliative care? How many disciplines have to be involved? How many domains of palliative care have to be involved till we call this, like, it reaches that bar? And I'm getting a sense from a CGA too, like there's probably a lot of variability in the studies out there. But it makes sense, Thiago, does comprehensive geriatric assessment do anything from an evidence perspective?
I think there's pretty good evidence that it does do something, and it's usually good stuff. Right. So there are even, more recent meta-analysis and several studies on different settings looking into how integrating CGA into care affect outcomes. And I think generally the results are pretty positive, in improving length of stay, improving, functional recovery, preventing longer hospital stays and readmissions. But there is some variability regarding, the costs and results in these different scenarios. So there are studies that were able, like in the inpatient setting, to find, benefits regarding functional outcomes, but then you might see some increase in costs. There are studies in the ED showing that, they were able to decrease costs and decrease their stay in the ED, but then the revisit rates increase a bit. So the different approaches to how you do it and how you do it integrate into these different scenarios do, affect the evidence. So, they're heterogeneous.
Yeah, I remember reading a meta-analysis. BMJ, I think back in 2011, did a meta-analysis looking at inpatient comprehensive geriatric assessment. People were more likely to be alive in-home for those who got the comprehensive geriatric assessment. And it seemed like it was, again, there's the variability. What do we call that? Like the more, like if it was its individual unit, I believe it actually maybe had a little bit more evidence than if it wasn't.
That's right.
Again, this variability of like, how are we delivering this comprehensive geriatric assessment?
Yeah.
Eric, you were going to say something?
And I think, I agree. And I think one of the factors is, if you do the assessment, but then the recommendations don't get implemented, then the effectiveness of that assessment would decrease, right? And so in a geriatric unit, it makes sense because there is, it's sort of like you're implementing everything that you recommend because the team works with you, and you could carry that through all the way till the end. And so that it makes sense, right? But in some other, models, maybe, just a consultation is delivered and, you rely on other providers to carry through those recommendations. And I think there have been some studies, especially in geriatric oncology, looking at what percentage of recommendations get implemented, and the numbers can vary quite a bit, can be low, and so that then the effectiveness might not be as good.
And I think that's a really important message because I feel that when we talk about CGAs, we often focus on the assessments and less so on the care plans. And that's really why we're doing it, right? We're not just there to, time how long someone takes to, get up and sit down, and sit on the chair. That's supposed to be used for something.
Yeah. So I'm hearing there is the assessment, there is the implementation. I also read, a third key component for a geriatric assessment is screening and targeting the right individuals. So that's really the first step is who benefits from this? Because I also read maybe there's spectrums, like very, very healthy older adults may not benefit it. Very, very sick older adults may not benefit from it. So is there a sweet spot? What do you think about that?
And I think that the very, very healthy is kind of intuitive. The very, very sick, I don't quite understand and would love to have an explanation about that.
If it's true what I read.
Mm-hmm.
Well, I mean, I agree, right? Like, so you have to, choose the right people. And I think part of the issue is if you don't do the assessment, you actually may not figure out all the issues that are hidden in somebody who otherwise appears healthy. So, at St. Michael's Hospital, we do automatic consults on, people over the age of 65 with a hip fracture. And we also see people over the age of 65 with a trauma. And we do automatic consults on all these people. And this is, pioneered by one of my colleagues, Dr. Camilla Wong, who, started these services and that we're working on.
But that's a very select population, right? Like the fact that they have a hip fracture.
Yes.
Means that something is going on. Like these are not like...
Yes, they're not general population.
Yeah.
I agree. But the hip fracture is one thing. So there's good evidence for that, right? Orthogeriatric care. But the geriatric trauma is a little bit interesting. So yes, a lot of them may have falls, right? They may fall down the stairs and fall itself would be a geriatric syndrome. So there's an inciting event and you're selecting for people who present with a geriatric syndrome. But there are also traumas where it's just a car accident, for example. Not just a car accident, but it's a car accident. Yeah. And then you have to actually dig further to figure out, like, were they the driver? Were they the passenger? What kind of injuries? But it's actually surprising because a lot of these people, just by age alone, they actually have issues that we can address. When we talk to the families, like they may be struggling with some cognitive changes that, because primary care there's a crisis in Canada. It's hard to find a family doctor. They may not have brought it up to anybody. And the first time is because we saw them. And it's just that they're older, right? And we're identifying these issues. And so there's a lot of cases where we could find something, even in people who don't specifically present with a geriatric syndrome.
Yeah. I think we have to be careful as well when we say that something doesn't work. We have to think on what kind of outcome is being used to say that it doesn't work, right? So, Alex, when you say that, I've heard that CJs that don't work for very old or very frail older adults. So, what doesn't it work for? So, it probably
isn't the primary thing everybody cares about? Patients is their length of stay and hospital utilization. That's what matters most, right? That's what matters most.
That's the last M.
Mortality or
profit margin for the healthcare industrial complex.
So there you go, right? So then it's probably not going to work. So there'll probably be, throughout the lifespan and complexity, there'll probably be components in the CGA that will be, stuff that you can intervene more or less depending on the patient. So you might not be able to improve their cognition, but you can, identify social support problems and help them address those issues. So, yeah.
Mm-hmm. I love that point. It reminds me of Ken Kavinsky during our last updates at AGS, where we were talking about hearing loss and the outcomes of like hearing aids with cognitive impairment. And ultimately, like the main point that I heard from Ken was, hey, just the fact that they can hear is an outcome that's good enough, right? Like you don't need to show like it prolongs life or it decreases cognitive impairment. Like they can hear. That's important.
Right.
That was a really good point. Yeah.
And Thiago, you mentioned when we first were asking you about what is a comprehensive geriatric assessment, you were talking about like prioritization, which to me reminds me of the what matters most. And I'm wondering is that a part of the comprehensive geriatric assessment?
It definitely should be, right? And now that you explicitly ask, and Eric can, tell us about his experience, but I think it's rare that a CGA model will explicitly have that component, like ask your patient what matters most.
Right.
It's more like what you as the provider is identifying as what matters most. But that would be a very good point that we should include that, that M more explicitly in the models.
What do you think, Eric?
Yeah, no, I agree. And so I think at the end of my consult notes, I often will try to have a point on future planning where I'll, in the right context, talk about goals of care, advanced care planning, and also what their preferences are. And in some consults, it's more important than others, right? When we see people, for example, with malignancy or with other end-stage diseases, it's more important to prioritize that and talk about those preferences. But sometimes even for my clinic patients, I will ask them, like, where do you see yourself aging? Like, do you want to stay in place and age at home? Or do you want to move in with one of your children? Or do you want, and some people actually want to go to a retirement home. They're like, I have friends who, are in the retirement home and they have a great time. And so how to get me into one of those places? And so, but I do find that if I don't ask that questions, people are either we're so focused on medical issues that we forget about it, or they don't know whether they should bring it up. And but asking that specifically is, I find it very helpful.
Yeah. And I think where I was reading about the spectrum, like the very, very healthy or the very, very sick is not like the little C comprehensive geriatric assessment. It was like the big C, like you get all of these team members, very intensive comprehensive geriatric assessment, assessing for everything, maybe taking hours or longer from this versus more usual care. But I do think like even in hospice care, like these things are important. Falls, function, incontinence, like it matters. So that little C comprehensive geriatric assessment still applies, it seems like. Would you agree with that?
Yeah. And I think it's something that Eric mentioned before, that the systematic aspect of, looking into all these things, I think it's what sets the CGAs apart. At the end of the day, I agree that, it's providing good care. It didn't have to be CGAs. You could do all of that and look into all of these issues without it, calling it the CGA, because it's good clinical care. But then doing it systematically will help you not forget about all these.
And it takes time, right? Systematic. This is not a 10, 15-minute appointment for one medical problem. This is, I hear you, Eric, 90 minutes, which for like primary care, they don't have 90 minutes.
No way.
So then the question I have is, when we think about prioritization, like who should be getting it and where, given that like the way the system is like, it's not resource unlimited. Like we have to think about the resources and where we should put in the resources. And it reminds me of the JAGS article that just came out, Eric, which Thiago did the editorial on money does matter, right? Like where we put our resources matter. Do you mind, Eric, just describing like in a quick nutshell? We won't get too method-y on this, but in a quick nutshell, kind of what you were hoping to achieve with this JAGS article?
Oh, I was actually just going to talk about methods. I thought that's what the article. I wasn't sure after.
Let's talk about it, because I got really confused. I read it like 3 times. Something about dominant versus
dominated.
Yeah, dominated. I'm all, wait, is this about something else than medicine? Domination? And
I know. I I heard some feedback. I didn't go to AGS, but I heard that this was discussed at AGS in some way.
Yeah.
We discussed it in the reviewing for JAGS workshop. And it was a great learning piece for participants. Eric,
we're just so grateful that that JAGS decided to accept the paper, and I'm very grateful to the editors and also to Thiago and to Say for writing that editorial, which I think helps people understand some of the limitations of the work we did, and also contextualizes, why this is important. So the whole premise of the study is there's a shortage of geriatricians, and the shortage of geriatricians is in Canada. For sure, Canada, we have a very low ratio per older adult compared to, say, the US or the UK, where there's an absolute larger geriatric workforce. So for Canada, this becomes a problem as our population ages. So one of the things that we thought about is, well, we always try to recruit more geriatricians, and that, I think there's a lot of people around the world who've tried different things to do that, but there are also some limits to that. So we're seeing that even with, trying to get people interested, we're not seeing as many people sort of applying. So then the other solution is, like, how do we optimize, right? How do we make good use of the existing workforce of geriatricians in a population that's going to age in the coming 10, 20 years? And so the question the direction that we wanted to take wasn't quite about models of care. So, earlier we talked a lot about, is it an ACE unit or is it a geriatric evaluation unit? We didn't focus on that because, that's been looked at, but it's also a little bit harder, right? Because it's context specific. So instead, we wanted to look at a more sort of a broader picture of just the healthcare settings, where there's a little bit more similarity, across the world. When somebody's in acute care, we kind of have a good sense of what those patients look like. When they're in rehab, which is a post-acute setting, we have a good sense and some similarities. And then in the community setting, coming into an outpatient clinic to see a doctor. So we wanted to focus on the settings and try to answer that question. If we could choose one or two settings, or if we didn't have enough people to staff all the settings, which healthcare settings should we prioritize geriatricians first? And so there's a two-part to this. And so there's a part of the study which was a systematic review and a network meta-analysis. That one we are working on updating, but we ended up doing the cost effectiveness first. But that study informed the cost effectiveness, where we designed a model. So it's a computer simulation model. And we looked at, older adults in Canada, in Ontario specifically, and we simulated what happened when we put geriatricians focus on different settings or different combination of settings, and what the overall outcome is for the population.
And is this geriatricians or comprehensive geriatric assessments?
Yes. So that's a great question. So it's actually also specifically, it's a geriatrician-led comprehensive geriatric assessment.
Okay.
Yes. And so the question is a little bit different than, should we do a CGA in which setting?
Yeah.
We don't quite answer that question. What we're answering is, because there's specifically a shortage of geriatricians, right? So we want to know where we should put the geriatricians to do the CGA. Hopefully that clarifies a little bit about the research question.
And the question is, where inpatient, rehab, outpatient, where should we target these geriatrician-led comprehensive geriatric assessments?
Yes, that's correct. And so then we ran the model. And so, yes, there's different terms. And I did, after getting some feedback.
This is where it gets a little 50 Shades of Gray, which I was not expecting.
I know. And I heard about
the
that.
domination.
But if,
I thought that should be your title, 50 Shades of Gray, where to insert geriatricians.
Oh, yeah, that would...
All right. Tell our audience, because they haven't read the paper probably. What did you find?
Right. So in terms of the strategies, when we rank the different strategies, and the strategy is just when we do the geriatric assessments in a certain setting, so we focus on one setting, or we deliver it in combination. So, for example, it's either acute care only, rehab only, or community clinics only, or we might combine them, say, acute care and rehab, acute care and community clinics, and so forth. And so what we found was that the best strategy, the optimal strategy, if there was a shortage, is to deliver the CJ in a combination of acute care and rehab. So
and this is what you called the dominant strategy, dominant, right?
We called it. We actually called it the undominated strategy.
Undominated.
Yes, I know. I know. It's
the non 50 Shades strategy. Okay.
Yes, it is a safe one.
Okay.
And so that one, because what happens is we rank all the strategies by lowest to highest cost. So the acute care and rehab strategy happened to be the lowest cost. And there wasn't a strategy that had a lower cost that delivered greater benefit. So therefore, it was undominated. But there was a second strategy later on, which is the triple strategy. So it's delivering the CJ in the acute care, rehab, and community settings, so everywhere, if local resources permit. And if you were able to do that, then it was still cost effective, because although the cost was higher, the benefit was also higher. And then we use a cost effectiveness threshold to determine whether a new intervention is cost effective, and it was below this threshold. And so for that, the term is cost effective. So that strategy is cost effective. The acute care and rehab is undominated.
Okay, so if you're resource limited, focus on acute care and rehab. If you got a lot of resources and geriatricians, you can focus on the spectrum, the whole spectrum. Is that right?
Yes.
And is there any place where it doesn't?
Where it doesn't work? No. Yeah. So actually, we also did a separate ranking. So traditionally, cost effectiveness analysis, we rank all of the strategies by lowest to highest cost, and then we compare each pairwise. So we always compare it one at a time, and usually compare it with the previous best strategy. But we decided to do an alternative ranking based on somebody on my PhD committee's suggestion, and we ranked each strategy against usual care. And every single one of the strategies is either dominant or is cost effective. So you can choose to deliver the CJ in any of those combinations or individual settings, and it would still be better than usual care.
Thiago, you wrote the editorial.
Yeah, that's right.
Thoughts on that paper?
First of all, I want to, jokes apart, I want to congratulate Eric and the co-authors on the work, and kudos for JAGS for bringing something that's not in our usual kind of, comfort zone. But I think it's really important that we, think about clinical care and in terms that are very important as well, economic aspects and so on. I think the main message, in the editorial say, and I discuss a little bit of the methods, some of the caveats and limitations that are important to our interpretation of the results. But I think the main message there is that, this is very interesting and good study showing that geriatricians doing one thing, CGAs, are cost effective and pretty good. And well, actually, geriatricians do a lot of other stuff, in addition to CGAs. So it's reasonable to, infer that the cost effectiveness and benefit is even greater than what was described. So it's important that we optimize resource allocation, but even more important that we get more geriatricians out there so everyone that needs them can have receive their care.
Eric, your big picture, what should we do with this study?
So when I try to explain this to, clinical audiences, and I know it's confusing to understand, but this is for an example of how you can use this information. Yeah. Say there was a new hospital or a new community setting where you're building a hospital. And in that local setting, in that local hospital, you have all of these, like you're building an acute care hospital, there's maybe an attached rehab unit, and then there's an outpatient clinic. And you're the first geriatrician there, right? You decided to apply and work there. And you're trying to figure out, well, I have all these places that I want to be, but there's only one of me and I can't work, I can't staff everything. And you try to recruit and you can maybe only recruit one person, or maybe it's just that, or just yourself. And so you have to decide, like, where am I going to focus my time, which is a realistic scenario, even in Ontario where we're at, and where we have all these hospitals further from the main city that are looking for geriatricians. And so for them, you can use the studies to sort of say, okay, so if I don't have enough geriatricians, I should really focus on the acute care side first and then spend some time at rehab. But that outpatient clinic, maybe we could wait until we have enough geriatricians to have them go there. And in the meantime, you can use, say, other providers. So there may be nurse practitioners, or in Ontario, we have family doctors who have care of the elderly training. So they could also staff the clinic settings until you have enough geriatricians to help out there.
I love it. Well, I want to thank both of you for being on this podcast. But before we end, we're going to go to Alex to do Billie Eilish. Which song was it again? Something about
Getting
aging.
older.
Getting older.
Getting older. In this case, from 18 to 19. I think she's a little older than that now.
I'm going to Wikipedia. I'll let you know after this song.
We'll see. Last week, I realized I crave pity. When I retell a story, I make everything sound worse. Can't shake the feeling that I'm just bad at healing. And maybe that's the reason every sentence sounds rehearsed. Which is ironic, because I wasn't honest. I was still being ignored, lying for attention, just to get neglection. Now we're estranged. Things I once enjoyed just keep me employed now. Things I'm longing for, someday I'll be bored of. It's so weird that we care so much until we don't.
Eric, Thiago, thanks for joining us on this podcast.
Thank you for having us.
And we will have links to the JAGS article, to both the article and the editorial on our show notes. So please check it out. And thank you to all of our listeners for your continued support. We'd also like to say a big thank you to those who've donated more than $250 to the GeriPal podcast over the last year, including
Anna Lynch, Deborah and Jeffrey Larson, Krista Mossack, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Castle, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Samoji, Matthew Schuster, Carrie Hagan, and Lloyd Woolstat.
a very big thank you. And if you too want to donate to the GeriPal podcast, please go to the GeriPal website and click on the blue or orange donate button.